Lee is on the line. Maria Lee is my sister, and she's a physician. She's a home care physician in New York City, Chinatown, and she's the one that connected me to all of you guys. And I just wanted to give her a little shout out. Okay. Anyway, so this is welcome to Anthony Dawson. He's RN, MSN. He is a senior clinical expert over at VNS NY. He heads up the clinical expert response team, and he's responsible for leading the development of all clinical protocols regarding the care and the treatment of COVID positive, COVID presumptive, and traditional home care protocols during this pandemic. He developed a bunch of PPE protocols to protect the nursing staff during this pandemic, and allows the visiting nurse staff to continue to provide safe care in New York City during the pandemic. So thank you so much, and you can take it away. Thank you.
Great, thank you. So can everybody hear me okay?
Yep.
Great. So thank you so much for inviting me and for giving me the opportunity to discuss some of the challenges and issues that we faced at VNSNY over the last few months, actually since March. And I'll give you a little overview to start with. If you go to the next slide, I'll give you an overview of who we are and what's Visiting Nurse Service of New York. So we have a traditional home care management organization. We see about 9,000 patients in that patient population. We touch about 45,000 patients a day. We have a hospice, end-of-life, and palliative care program, and we've about 1,400 patients in that program. And actually, in the last couple of weeks, we have surpassed our hospice volume at the highest it's ever been. And I think that's part of COVID, and I'll talk a little bit more about that in a few minutes as to why. We also have a home health aid service. We have about 9,000 home health aides that provide care, anywhere from 2 hours to 24 hours a day care across our continuum. We have an MLTC with about 23,000 members. And then we also have a community mental health program where we see about 14,000 clients a year in that program. If I could get the next slide, please. So what was our response to the COVID pandemic? It takes sort of 3 steps. First of all, the first guiding principle that we followed was that we had to be able to protect our patients and our staff. That we had to be able to address New York City's public health needs by supporting and decompressing our local inpatient facilities. As I'm sure you've read and I'm sure you've seen on TV, hospitals were pretty overwhelmed very fast. And once those hospitals started to get overwhelmed and their capacity started to grow, they also started to need to be able to discharge patients faster. So that was discharge of their regular patients, but also discharge of their COVID patients who were coming to the emergency room, being treated and released, and then being discharged. And I'll talk more about that in a few minutes. And then we also wanted to mitigate the impact of the organization where possible. So the first thing we did was we shifted our office-based staff to remote work. And we did that over about a week and a half process where we actually moved thousands of staff off-site back out of the offices. We're actually situated in 42nd Street and 2nd Avenue in Manhattan, so smack in the middle of New York City. We employed communication for that staff. We developed HR policies, employee support. We supplied and procured PPE for them. And then we also started what we call a clinical response and service delivery for our CHA, hospice, or personal care services. We transitioned as much of the care as we could to virtual care, at least at the beginning. However, that wasn't as successful as we thought it was going to be. We developed home care criteria. We developed specific considerations for hospice, and I'll talk more about that in a few minutes. And we developed PPE protocols for every type of patient that we would see. And we also had to think about our regulatory considerations and our advocacy priorities. You can go to the next slide. So this is really the response line, and this tells you from February 17th to around the 29th, we started our emergency planning. And as you can imagine, that was pretty much 7 days a week just to start getting people off site and to start being able to see our patients. Our phase 2 was a mobilization where we protected our patients and our staff and secured PPE and moved as much as we could to telework. And then the third phase was really protecting our patients and our staff, decompressing the overwhelmed hospitals, care for the COVID positive patient, and being able to actually take those patients home. And so you can imagine the stress and anxiety that caused for our staff, all of a sudden seeing these COVID positive patients that they had never ever seen before. You can go to the next slide. So this is just an example of how we divided. So we had 8 different groups that we worked. Those 8 groups really coalesced and worked as a united team. So there was an executive team and we had a leaders daily call at 8:30 a.m. We had an emergency response planning team, and there's 45 leaders in that, and that convened every morning at 9 a.m. We had a clinical infection control leadership team, and that was at 10 o'clock every morning. And then we had a clinical emergency response hotline team. And I'll talk much more about CERD in a few minutes, because that was a pretty innovative approach that we did to be able to create, for want of a better word, an emergency response team that was available 24 hours a day, 7 days a week, and be able to be responsible for our patients and for our staff. We also had to become a supply and PPE procurement and management organization. And as a regular home care, you can imagine the most PPE we'd ever wear would be a gown and gloves and perhaps a mask for MRSA patients. All of a sudden, we had to procure our own PPE. And when I can tell you that was difficult, it was extremely difficult, because the hospitals all got PPE from the federal government, and the hospitals got PPE from the local departments of health. And it wasn't until about a week and a half into this March where we worked with the Department of Health in New York City and eventually got them to understand that we also needed PPE in order for us to be able to see patients. We had a workforce and human resource daily calls, and then regulatory affairs and compliance, because as you probably know, many of the regulatory regulations changed over time, and they change almost daily. There were issuance of guidance from the Department of Health and also from the CDC, the FDA, from World Health Organization. And so there was many competing and oftentimes challenging protocols that were coming from them. And then the financial tracking and metrics was obviously looking at our finances and our tracking and how we were doing as we moved forward. You can move forward, please. So this is the clinical expert response team, and what this is basically was a team that we set up and as a group of certified nurses. And you can imagine that given our size, we have a pretty robust human resources, but we've got a very small employee health section, right? There's only 3 nurses in that for the entire organization. But we needed to be able to now manage hundreds and hundreds of staff and hundreds of staff calls, and also hundreds and hundreds of staff who called out sick because they were either scared or they were afraid that they were going to infect their significant others or their children at home. And so we had to be able to manage that team. And so we created what we call our clinical expert response team. We created that for both the CHA, hospice, and our CMO. And we also created a separate one for our home health aides. So as I said to you before, we've got 9,000 home health aides, and you can imagine the fear and anxiety that they had, but we had to be able to manage them on a daily basis and be able to answer their calls too. So as I said, both those CERT teams worked from 8 to 5, and then on the off shifts, we have a central call center that patients and our family members can call into, and we use that to cover the 24 hours a day. The graphs on the right-hand side just show you the number of calls that we were getting, and we were able to track those and trend those over time. And you can see at the height of this that many people were calling in, hundreds of calls a day, and they started to trail off. And then on the bottom, you can see we developed clinical protocols to either send employees home if they were sick and or had symptoms, and then a mechanism to be able to bring them back safely if they, A, were not sick, and B, if they had gone over their COVID. Now, remember at this time too, we had very, very little testing in New York City. It took us weeks before we actually got actual tests to be available to be able to test our staff and our patients. You could go to the next slide, please. So communication, communication, communication. I can't stress this enough for you with the amount of information that we had to be able to share with our teams. And in particular, now all of our staff were off-site, so they were no longer in conference rooms, they were no longer meeting. We had to have a communication strategy for them. And what we created was a COVID-19 update site on our intranet. And under that site, there was a clinical component, there was a HR component, there was a finance component. So things were placed into those different buckets and people had the information at their fingertips if they had questions about anything. We also engaged staff through other channels. We had daily inspirational audio messages from our CEO, and to this day, she's still doing those. So it's 30 seconds of a video message every morning. We had weekly all staff calls, and we continue to do those today. So that's an opportunity that's on a Tuesday. We do it twice on a Tuesday at 9 and again at 3 o'clock. And literally 1,000 to 2,000 people call into that video line. We do a presentation and then we answer questions live for the staff so that they have a mechanism to hear and also have their questions answered. Again, as I said, you have to create a mechanism so there's two-way communication so that everybody knows what's going on. You can go to the next slide, please. So let me talk a little about the virtual care. We transitioned our child and our hospice to virtual care where possible. We developed new patient triage methodology to identify which visits would occur. We also identified abilities so that we weren't having a PT, OT, and a nurse all going into the same home. Because again, if the patient was COVID positive and or COVID suspect, we didn't want all those people going into that patient's home. So we developed protocols around that. We updated our admission criteria to effectively triage patients so we knew who was coming to us and if the patient was COVID positive. We created virtual visit guidelines and followed clinicians to collaborate on ordering physicians to document updates and plans of care. And we allowed for temporary use of various virtual visits by those that were allowed by CMS and our Department of Health, including FaceTime, WhatsApp, etc. And VNSNY did not at that time have a robust video conferencing type of mechanism on the smart tablets for the nursing staff or the staff. You can go to the next slide, please. So given the acute staffing shortage, we adapted our services to ensure we prioritized our patients. So again, protection of patients and clinical staff from COVID exposure. We support our local hospitals by decompressing them as much as we could. And then we also developed criteria to prioritize admissions and considered essential. So initially, who were the essential patients that we needed to take? And then were there patients that did not need home care services, but would just want home care services? And the other thing that happened in New York City was all elective surgery stopped. So a lot of our regular cases just stopped coming to us because all elective surgery stopped. And so there was a very different mix of patients started to come to us. So a note on the timing of the first COVID admissions that we saw, we didn't see those until March, and that was only after we received initial emergency supply from the New York City Office of Emergency Management on PPE. Because again, we just did not have that. We did not have N95 masks. We did not have sufficient gowns. We did not have sufficient gloves and all those supplies to be able to take care of COVID positive patients. You can go to the next slide, please. So here's some of the other things that we talked about or thought about was that, first of all, as patients were being discharged, we wanted them to have the supplies and equipment in their home. We verified whether there was a pulse oximeter being sent home with the COVID positive patients. And we verified whether there were aerosol treatments involved because they are higher risk for us. And so we had to do our timing around those visits. So if the patient had nebulizer treatment at 8 o'clock in the morning, we either saw them before that, we saw them after that. So we weren't being exposed. We also asked that that there was caregivers in place to be able to take care of the patient if we were not being able to do that, and when we were in the home with them. We ensured that patients had means of receiving their medications, and again, lots of places closed down, and so medications and things like that were in a short supply for a few weeks until pharmacies got ahead of this and started to get back up to speed. And then we also worked with our physician colleagues to make sure that we had physician coverage and that every patient that was discharged had a mechanism to be seen by a physician or have physician orders as that patient got discharged. Next slide, please. So here are some of the hospice considerations, and I think this was, pretty heroic. So hospice really never stopped seeing their patients. And as I said to you at the very beginning, our hospice census is higher than it's ever been. And I think that's for a number of different reasons. One, the number of patients that are coming to us and coming to us very fast. The number of COVID patients coming to us that are coming to us and dying very fast. And so that's both an opportunity and a challenge for us because we don't get to know those hospice patients anymore. They may only be on service with us for 2 or 3 days and they're dying. So that's a huge challenge for us. Hospice continued to see patients, as I said. The hospice staff were wearing full PPE as they were going to see those patients, and I'll talk about what that looks like in a few minutes. The IDG team, our interdisciplinary members team, continued to play a vital role in making sure that those patients were serviced and were seen appropriately. The hospice physicians played a key role in e-prescribing medication to our patients and also certifying deaths. Our online social work support provided an entire VNSNY entity. We had some staff shortages, beginning, especially at the epicenter of this, again, as staff called out and were afraid to come to work. And then a huge issue for us, and I know that you'll find this hard to believe, is that we had huge problems with body removal because the funeral homes were totally overwhelmed and bodies were being left in people's homes for prolonged periods of time. And we had to work with the medical examiner's office to make sure that those patients who had died were being removed from patients' homes as soon as they could. Also then that we had bereavement services and the impact of COVID for those patients. Next slide, please. This is just a disclaimer because we developed all these protocols, and so you're welcome to use those, but please don't come after us if they're wrong or they don't work for you. You can go to the next slide. So here's some of the stuff that we developed on the slides on the right-hand side, and all of this is available on our website. And these are the training protocols we put in place around PPE, and we developed our protocols A through D. And I'll explain what that is in a few minutes, around A being the patient who comes out to us that was newly diagnosed. B is the patient who comes to us that we were not sure of if they were COVID positive, but most likely they were. C was the patient who was maybe negative, but there was a COVID positive patient in their home. And then D is the COVID negative patient or patients who are negative all along. So we had to train our remote staff on PPE protocols. So normally we would bring all of that staff into a classroom. We would put them down in front of a trainer. We would do 8 hours of training for them. We had to be able to do that remotely with thousands of nurses and thousands of home health aides. So we had to develop video training programs very fast, and none of this was online. And the PPE protocols were all around providing care for patients in a hospital, not providing care in the home. So where did you don and doff your PPE? Where did you dispose of your PPE in the patient's home? How did you do that in an apartment building? How did you do that in a one-bedroom apartment building? How did you do that in a house? So we walked through all those protocols and developed those for every scenario that we could think of. We embedded checklists for donning and doffing and taught people how to don and doff in an appropriate fashion. We tailored the approach to the staff expertise. So some staff were really great, and then other staff had never put on PPE in their life, so we had to teach everybody. We had managers go to our supply centers and our distribution centers, and they proctored people to be able to don and doff appropriately and did return demonstrations with them. We became a distribution center for supplies, and we developed COVID kits, and those COVID kits contain the appropriate PPE depending on the type of patient we saw. We also mailed to the home health aides N95 masks, regular surgical masks, and PPE supplies to their homes. And we did an outreach to over 7,000 home health aides, where we called every single one of them. We sent them education materials, and then we went through the education materials with each of those 7,000 staff. Next slide, please. We also had to think about reuse of scarce supplies, which was including reuse of N95 masks, reuse of face shields, in fact, reuse of surgical masks at the beginning because of the supply shortages. That created its own infection control issues, especially about how you clean things and what you cleaned things with. So how do you clean a face shield? How do you do that in patient's home? How do you do that without contaminating yourself? And how do you do that without contaminating the patient? Procurement of supplies and counterfeit products, I'll talk about that in just a few minutes. And then the huge variability in products. So we had to keep on top of things that would come to us. So simple things like alcohol solution that we used to come in these little bottles now came in a gallon jar that we had to be able to dispense into smaller bottles. The products that they were used to seeing isn't the product that they get today because of the shortage of supplies, and a wide range of new products and things that went on. On the right-hand side, you'll see the extended use of PPE and how we went through that for every single thing that we use, from, N95 masks to regular surgical masks. And you can go to the next slide. Now, I can't stress with you enough the influx of products that we got that were counterfeit. In the height of this pandemic, everybody was vying for the same PPE. We were competing against each other for the same PPE. And even though we have a procurement group that's normally supplying, supplies to our home health staff, we started to see N95 masks that were not N95 masks. So that became a whole other industry where we had to do research on every product that we bought. And the bottom example is a real N95 mask, and that's NIOSH approved, and that it's approved by the CDC and the FDA. So that became another whole issue for us and a way for us to be able to keep our staff safe. You can go to the next slide. So here are the kits that we put together. So these are the starter care kits. So we put together kits where we actually put together kits for N95 respirator masks, surgical masks, gowns, gloves, face shields, paper bags to store the N95 masks, stethoscopes, and blood pressure cuffs. And we left those type of equipment in the patient's home, and we only carried the PPE with us. And then we replenished that every single time that the nurse had to go see the patient. For the home health aides, we restricted the amount of hours that they were with a COVID positive patient to 2 hours, because we didn't want those home health aides in the home longer than 2 hours in full PPE. It's extremely difficult to wear that N95 mask for that period of time, plus gown, gloves, masks, the whole shebang. So we also did those changes as we went along. You can go to the next slide. So these are the protocols that we developed. As I said earlier on, these are taking care of the patient who is low risk. That would be protocol A. Protocol B is the higher risk patient, that they are screened and in the emergency room. They were discharged. They may not have been tested, but they were presumptive COVID. And then we had specific criteria to follow with PPE for those patients. Since I put together these slides, we've actually gone from, instead of A through D, we now just have A through C. And we've actually expanded these out even further. And I'm happy to share those with you at tomorrow or whatever, when I get back into my office, and I can share those with you. You can go to the next slide. And here again are just the protocol C and the protocol D patients. And again, protocol C were patients who were negative, but their household member was positive. One of the things that we found, especially in New York City, was that patients may be discharged home and we're told to isolate for 14 days. Well, they were going home to a 2-bedroom apartment or a 1-bedroom apartment, and they may have 2 or 3 people living in that apartment with them. So it really wasn't realistic for those patients to isolate by themselves and to be able to do that. So that became a huge problem for us. And so many times we would walk into a patient's home knowing that the patient was COVID positive, only to find out that the mother, grandmother, or the kids were also there and were also COVID positive. You can go to the next slide. So here's some other things to think about. Before we get to this list, the things that we're dealing with now are that skilled nursing facilities and long-term care facilities are now requiring us to be the staff who go into those facilities to be tested once a week. So we have to test our staff before they go to see those patients. New York City and Department of Health and the state requires that every single patient in those facilities gets tested weekly. So not only are they testing the clients, they're also testing the staff that go in there. And we have to be able to track and trend that. And we have to be able to prove that we tested our staff before they go to those facilities. So as on a call today, we have about 120 staff that we now need to test every single week in order to take care of those patients in those specific homes. We also are required to do daily employee screenings where the staff are required to take their temperature before they come to work, and they fill in an online application. And again, being able to keep on top of that. As I said, the CERT team and being able to do that and have enough of a support staff around that to be able to support your staff in the field. Keeping the employees and patients safe, not seeing COVID positive patients until we had sufficient PPE, as I said before. Full PPE for our hospice staff, specifically because they were higher risk. Also, the other issues that we found were PPE and HIPAA. So all of a sudden we were dressing out in the middle of a hallway or in an apartment building, and then the neighbors are asking, why are you dressed in that outfit outside that person's home? So we had a whole load of HIPAA issues around that and what we could say and what we couldn't say. And then the clients were getting upset because we were dressing in full PPE coming to their house. There was also rapid discharges from hospitals and from the emergency rooms as they got overwhelmed, and they were sending the worried well and the sick home very fast. But those patients had underlying conditions such as COPD, CHF, heart failure, whatever. And so being able to manage a pretty sick population at the same time we were taking care of COVID patients. Discharges from SNFs and long-term care facilities became particularly problematic because they were the most positive patients we were seeing. And we had to make sure that we were using full PPE for any of those patients that were getting discharged and that we were taking with us. Transport to and from work, crowded subways, crowded buses, and we have our own staff on those modes of transportation coming to see patients and coming to see our clients. We procured parking passes for our nurses in New York City. And for any of you who've been to New York City, you know that it is densely populated and trying to find a parking space is like trying to save your life. So we actually got parking spaces, passes for the staff to be able to do that efficiently. As we've transitioned out of this, we're beginning to see that hospitals are starting to open. They're starting to see elective surgeries again. But part of what they're doing now is also creating COVID-only units and COVID-only hospitals, especially the larger systems, so that they can take care of the patients. Elective and urgent surgeries are beginning to come back, but again, at a slower pace than we thought. We are testing and tracing patients as much as we can, and testing and tracing staff as much as we can. We're preparing for the fall in case there's another wave of this. And we're particularly concerned around the flu vaccinations and what's going on with that. And then we're preparing for audits and inspections because the Department of Health never goes away. And we continue to get audits and inspections from them, regardless of the fact that we're in the midst of a pandemic. Here, you can go to the next slide. And here are all of the protocols. They're all online. You have access to those if you go to the VNSNY website. And I think that's it.
Hey, wow, thanks so much. There's somebody walking around. If you could mute your phone and we can hear you. Anyway, yeah, thanks so much from that perspective. I actually anticipate we probably have a lot of different comments or questions from our audience, folks here. I don't know if Karina Lee is on. If you are, can you identify yourself? Okay, well, I guess she's not on. I had spoken to her earlier, and she is one of the head folks at the Chinese American Planning Council of Home Attendance Program. And so basically, I was hoping she would kind of give us a little perspective on the impact on the home attendants, and how she said, she was telling me how like a third of them like dropped off.
Yes.
And that's a huge number to suddenly reduce your staff.
Right.
And so how did you deal with that?
So again, well, two things happened, right? So the home health aid volume, the home health aid started to disappear. They sort of went back in the shell and said, I'm not going to work, I'm afraid. I'm only coming back when COVID's over. And we also had a significant drop off in the number of patients who wanted a home health aid in their home, regardless of the fact that they needed them. So they decided it's safer for me not to have my home health aid, but in a way that was worse for them, because then they were falling and ended up in the hospital. So they almost balanced each other out. The volume went down and the home health aides went down. But as I said to you, we did a lot of outreach to our home health aides. We did individual calls to 7,000 of those, where we were doing training with every one of them over the phone. And we also, as they started to see COVID positive patients, we brought them back to our distribution center to make sure that they could do donning and doffing the PPE in an appropriate manner. And a lot of this was just getting them comfortable and educated and making sure that they were safe, right? So we, gave them N95 masks. We gave them masks. We gave them masks to take care of themselves. We gave them masks so they could go on the subways and on the buses. Many of those used public transport to go to and from work. So we had to be able to protect them too.
So yeah, basically a lot of education and armed and ready.
Right.
And they were okay to go back to work.
Yeah.
That's critical, right? Yeah. I just wanted to maybe open this up, see if Corinne had any comments. Corinne Suzuka from Care Resource. Questions, comments? Or maybe you could share with us what you've been doing with Care Resource in Hawaii.
Yeah, so actually, we're up to the point, we haven't had COVID patients. We've had PUIs. So definitely up to the point where you saw the COVID patients, I'm happy that we're on track, but I love the idea of having kits that you have. I think it's such a great program. Always looking up to VNSNY anyway, but I think the HIPAA part I was concerned about, because we undress and, outside the home. There is no way we can do it in the home. But I don't have anything to say to the people outside what to do. So I'm going to look at all your protocols and see what it says. But I think we were trying to duplicate that, even if we weren't in the midst of all of it and trying to develop protocols. We are actually looking at, the hospital having all the COVID, but we were just taking out the patients who were well or just a chronic diseases and those kind of things. So we are trying to prepare. We still have a difficult time looking for PPE, just as you have had. We at Care Resource only have about 290 staff, so not anything close to what you have. But so on the smaller scale, we're trying to accomplish the same protocols that you have. So thank you so much for giving the presentation. Really appreciate it.
Sure. I think one of the other things that I also failed to mention is that we also had a number of our patients, our staff who died, who actually contacted COVID and died. And so the other part of that was balancing that information with the rest of the staff and making sure that they were okay to go back into homes and take care of patients. And so and the majority of those who died were actually our home health aides. And we don't know if they, most of that, we believe at least, was community spread, because they weren't necessarily in hospitals, but they were maybe exposed to a patient at home, and or a patient who was in the hospital and came home, and we didn't know that they were COVID positive. Yeah. So just something else to think about as you, hopefully you don't have that journey, but we certainly have and continue to have.
So you must have had to have a kind of robust, like, mental health for your staff. I mean, I know for hospice you do it for the patients, but you really had to have it for your staff.
Yes. So one of the things we did was actually our community mental health program. They were fantastic, and they actually did video conferences with groups of staff, and especially in the midst of this, when it was so hard, and most of us were working 12, 14 hours a day, 7 days a week, and that becomes very exhausting. And just to be able to get on a group chat like this and be able to talk about some of the feelings and some of the feeling inadequate, and we weren't doing enough, and we weren't able to do everything, and that was really helpful. And I can't tell you how helpful that, I think, was to many staff. Some people just called in and didn't say anything, but just listened, and that's okay too. And some people got on, were very verbal and were very upset. And our grief counselors in hospice also did the same thing for us, and they did an amazing job of being able to reach out to staff who are having a hard time.
Thank you.
Sure.
Gary Wong, I know you're on there too. Thanks for joining us. Do you have questions as well, or comments on what Bayada is doing? Or
yeah, thanks for having me. I don't really have any questions. I'll tell you, as I was watching Anthony present, I think Bayada must have been tapping into their resources, because our protocols are very, very similar to what he presented. We have 9 different service lines over 7 countries. There's over 100 home health, Medicare certified home health agencies in the practice, again, throughout the country. And, those protocols and a lot of their resources they have, we have the same resources. We have an entire section of our portal website dedicated to this, that basically all directors and divisional support people can go to and source from. Like Corinne, we have not had a large volume, but we're extremely prepared. But our headquarters is in New Jersey, and New Jersey was hit pretty hard. And so we do have offices that really did go through similar events like Anthony's organization. And so we feel all the better prepared here, because we have sister offices that have gone through it, and all the training tools and videos and whatnot have been prepared, and our staff are more or less prepared. We are also fortunate that we have centralized our PPE. So each region has a supply lieutenant. I happen to be the supply lieutenant for Hawaii for Bayada, and we can basically access that PPE center. So we do it on a patient-by-patient basis. So we get a patient that has a certain profile, we send it to them. They may send out a PPE kit to us, or they may send out a whole bucket of PPE, depending on what the situation is. And then I'll give you an example. Maui Memorial, when they had that little cluster, we got a bunch of PPE sent out to our home health agency there. So yeah, great presentation though.
One thing. So normally, if we have like an MRSA patient, we would send that PPE to the patient's home, and it would be just there. So our initial nurses were saying, well, we're not going to carry this PPE from home to home, and why don't you just send it to the patient's home? So we were sending it to patients' homes, and the patients were wearing it, and the family members were wearing it. So then we had to stop and rethink that whole thing. And of course, only in New York would you have family members wearing the supplies that we send them. So we had to rethink all of that, and especially with shortage of PPE. So I would tell everybody on this call, be prepared for that, and be prepared for a lot of PPE. I can't tell you the amount of stuff that we've burned through very fast. And I think, I don't think we underestimated that. I just think that we didn't think that we would use it as fast as we have and continue to use it. So you may think that you've got a lot, but when you think about when you're doing that multiple times a day and changing that multiple times a week, it burns through very fast. Great question. Thanks.
Okay, so we have a comment from Jeanette Kojane. Can you talk about the role of, I guess we have Pulse here and advanced directives.
Yes.
What what is your home health agency doing with regards to that?
So we still have those. So we have EMOst for our hospice patients, and we do those. So patients were still coming out with those. The again, as I said to you, the particular issue on the hospice side was that some of those patients are coming to us very fast, and we don't, so normally they would come to us, we would do a full admission, we would do all those things. But when at the height of this, those patients start to come to us pretty fast, and keeping up with those admissions and keeping up with the protocols with those patients was certainly a challenge. It's sort of leveled off somewhat now, but again, those patients tend to be dying faster because they're so sick, and the family members are very needy because they don't have that time to grieve. They don't have that time to think about their loved one's going to die. And so, many patients who were on ventilators or whatever from the hospital or discharged home with underlying conditions and then just died. So it's been a challenge. It's certainly been a challenge for us.
Yeah, I see that we have some hospice colleagues here on the line, and I wonder if they want to share any comments about their experience. They're being shy.
That's okay.
It's okay. All right. We have another question here to our local agencies. How are you handling clients who have families and visitors from out of state who are quarantining with them in their home? Yeah.
Great question.
Even come and provide care too.
Yeah. So initially, so when the initial COVID pandemic hit New York, we had a lot of family members who had sons, daughters, relatives in other countries who then came home. And so we developed screening tool questions. So we call every patient before we go to their home, ask them if they have COVID-like symptoms, the specific questions that we ask. And then we also ask about family members. Was there a family member at home? Is there a family member who's traveled within the last 14 days? Is there a family member who's recently come home from a trip? So again, even though we ask those questions, some family members lied to us because they didn't want us not to come. And so we would go to the home and find out that the son, who had just spent, a week in Brazil, is home and sitting in the kitchen. And we're like, oh. So we were very cautious about those. And up until today, we're still cautious about family members who say, in fact, we had a hospice patient last week. The husband was COVID positive. He was the caregiver for the wife. The wife was COVID negative, and we had a home health aide in the home. And so we had to go through that whole piece so that he was in a different room when we came to visit and was isolated. And again, as much of that as we can do, we do. But again, we're in the appropriate PPE, so we're not exposing our staff.
Yeah,
it's a challenge. Yeah.
I'll just add on to that. I mean, very similar again, Anthony, that for us, we ask questions of every patient before admission through our screening process. Similar questions about anybody travel, symptoms, and the symptom list used to be 3 symptoms, and now it's a list of, I think, 12.
Right.
It keeps growing.
Yep.
And then once we get to that place where I think Janelle put in her question, we do have guidance. And the guidance is around, is this person quarantining and they have no symptoms, right? Then we're most likely going in just with a surgical mask. If they have symptoms, and I'm just checking our PPE guidance here, we are wearing gown, gloves, and mask. And then if they test positive, we might treat them like a presumptive positive if we don't feel like they're distancing them from the patient, right? So when you're visiting, you are asking them to be in a different room, but you can get a feel right away if you feel like this is happening when you're not there.
Sure.
I tend to think it's not happening, so I'm going to presume positive while that household member is positive.
So on our, and I don't know if it's on our, I think it's on our Infonet site, we had a nurse who visited a patient in the Bronx, and he was in a one-room apartment with 6 family members, and all 6 family members ended up getting COVID. The father was in hospital, contacted COVID, was sent home, and because of the proximity, I mean, they had nowhere else to go. And so I was on a call a few weeks ago with a different group, and they were like, and they're from all over the country, and they're like, well, that doesn't make sense. I'm like, no, we're in the middle of Manhattan. 6 people live in one-room apartment. It's like, that's the way it is. And so you have to be prepared for that, and I think you have to overthink that a little bit, because sometimes you just don't know what you're walking into, and you don't know what they're being doing before you get there for the visit.
Okay. We have a question. Have you encountered any staff that are part-time or on call working at other healthcare facilities or agencies? If so, how have you dealt with that?
Again, if they come then and work for us, they have to follow our protocols and follow our PPE guidance. So yes, we've had other, especially nurses who may be working in a hospital that may be working for part-time for us. And so again, provided they were following our screening protocols, following our employee health screening tool every day, they could continue to work for us. That's not an issue. In fact, we needed those people working for us as we went along.
Yeah. Anybody have any other questions? Yeah, we had some clusters of care homes here who just had positive, and then their whole family, was positive as well. And of course, then you have people who are afraid to. And then the care homes, the care home operators, they're sick, so they can't take care of their clients.
Sure.
And so that also can run into a bunch of problems. Oh, I have here, who pays for the COVID test for the staff? Yeah, I mean, for the patients we know, right? But for the staff.
Yes. So a number of different things. So right now, the insurance companies are paying for that. And if in New York City, at least in New York State, if you cannot afford it, the Department of Health is paying for that. So if you can't afford that, but our health insurance is paying for that right now, for that test, for that testing. We're exploring all sorts of things about testing, and what do we do testing ourselves? What do we outsource that? The test right now costs about $125 each time.
Okay, and here's a very recent problem we've had. What have you done if staff works at another facility that has a COVID positive case or an outbreak? Are they removed from the schedule for a certain period of time? Or do you just gown them up and get them out?
No. So what we actually do is they self-monitor, as I said, every day. And then if they have any types of sign, we broke that into 2 different things. So say they wake up and they have a headache and a sore throat, then they go off duty for 24 hours. If they have more progressive symptoms, they're off duty for 10 days. And then they have to be cleared by employee health before they come back to work. So they have to self-quarantine for that period of time. But again, on top of this, we had allergy season. So we had lots of people that said, these are just my allergies. I know they're my allergies. I don't have COVID. I haven't been around anybody that's COVID. And so it's a balance act between when you took somebody back and when you put somebody off. And the CERT team was responsible for making that decision. Staff had to call into that centralized number and say, I woke up this morning, I've got a temperature, I have a headache, and I have a sore throat. Then they got put off for 24 hours. After 24 hours, if they had if their symptoms did not improve off medication, they could come back to work. If they progressed, then they were put off for 10 days. So we have pretty strict protocols around that too.
Yeah, good.
Great question.
Yeah. Do you advocate goggles or face shields?
We advocated face shields only because we figured that the goggles were too difficult to put on and off, and also for contamination. So, and being able to clean those. So being able to actually take that goggle off without touching your face versus the whole face shield was easier for us. We do have goggles. We have both, but staff actually prefer the face shields.
Okay, oh, here's a real practical question. What are the quantities of each PPE in the kits provided? Trying to figure out what a COVID kit looks like for our our care homes and foster family homes.
This is a $6 million question. We have changed the quantities in those kits more times than I've had hot dinners since this thing started. So we started off with 2 N95 masks, 5 surgical masks, 5 gowns, and gloves, booties, and head covers in a kit. We then went up to 10 because people didn't want to keep on coming back to the office to pick up the kits. And now we've got a combination of both. And then we took the N95 masks out of the kits altogether because it was just creating havoc. So now it's just, I think it's back to, I think it's 10 gowns, 10 masks, a box of gloves that they get because the gloves have to be their size, and then shoe covers and head covers. And face shields.
So where do they get the N95s?
We give them two N95s separately in a bag.
Who distributes the
COVID kits?
Yeah.
Good question. So normally we have 5 regional offices where we distribute. They call them bag rooms, for want of a better word, where the nurses typically come and pick up their supplies. And so that's pretty scarcely staffed, as you can imagine. There's probably, I think, total of like 12 staff that staff all those centers. So we actually used volunteers, so staff that got moved out from their regular jobs. So people in HR, people from strategy, people that weren't doing their regular job, actually staffed the distribution centers. And we have just outsourced that now to a company that's going to build those for us. But we actually have staff doing that 7 days a week in those distribution centers, putting together kits. Yeah.
Yeah. So.
Good question.
Yeah. Oh, let's see. We have here.
Are you using the burn rate calculator? Yes.
Yeah.
Yes.
Who distributes the? Who distributes as are you using the burn rate calculator? Yeah.
Yes. So every day we also have to submit a herd survey to the Department of Health on what's on hand, what's the burn rate, and what's your projection for everything from thermometers, stethoscopes, blood pressure cuffs, face shields, gloves, gowns, the entire thing.
Oh, yeah. We have military folks here. Do you have employees required to travel for military or job and then exempt from quarantine period?
I don't know the answer to that question.
Oh, okay.
Honestly. I don't think so. I don't think that has come up, actually. That's a great question.
Okay, great. Any other comments from, let's see. Have you folks received any assistance with PPE supply from FEMA?
So, yes. So not so much from FEMA, but from our local Department of Health. And again, while the Department of Health was great, and while the various organizations sent us supplies, we had to be very careful about what we got, because some of the supplies we got were expired and some of the supplies we got were not N95 masks, even though they were touted as that. So yes, we got some supplies, and our biggest supply was from the Department of Health in the initial phase, so that we were able to see patients. So just a word of caution on that. People were great about sending us stuff, and we even had lots of our volunteers making face masks, thinking that we could all wear those in the home, but we actually ended up giving those to the patients. So we actually give the patient a face mask when we go in, so the patient's wearing a mask and we are too. So yeah, just be careful on that piece around where you're getting your supplies from and are they real.
Great. So for us, we're still we're getting ready for a surge. What's the top 3 things you think we need to do?
I think having enough supplies, as I said before. I think getting your staff comfortable with wearing PPE. I don't know how hot it is there, but it's getting hot here in New York City. and it's becoming more and more of a challenge to be wearing full PPE. So I think that's another thing. And then I think that the third thing is just supporting the staff every single day, and knowing that they've got somebody to call, or especially with questions. And I can't tell you, doing those conference calls every single week, it never surprised me the questions that staff have, and just don't take it for granted that they know everything they're doing. Sometimes they just don't know. They've got a question that's worrying them, and you're able to answer that question, let them be comfortable doing the next part of their job.
Thank you.
Sure.
So any last minute questions? It's 2:59.
Oh, it's only 9 o'clock here.
Oh, sorry. Hey, Maria, I just want to say hi. I gave a shout out earlier to thank you for referring Anthony Dawson to us. Thank you. I don't know if you have any comments. You have to unmute yourself if you want to say something.
Okay, I got it. I thought I was unmuted. Yes, Anthony Dawson, thank you so much for doing this. This is wonderful. I thought of you guys first because, you know, I work a lot with the Visiting Nurse Service of New York in all capacities, with the hospice, with the home care. You know, I see partners in care, the home health aides, in the MLTCs. So thank you for your input. And I've learned a bit from here too, actually. But you know, I've heard anecdotally stories from all the nurses themselves. Great. And the struggles that they're going through. The PPE shortage, definitely a big one. A number of the staff have become sick. Some of them are sick right now, are out. So it's been a very traumatic several months, losing patients and losing family members, home health aides to COVID, losing nurses to COVID. I guess, yeah, doctors to COVID. So it's real.
It is real.
It's not fake news, it's real.
It sure is real. It's been a challenge all around. But look, I get to work for a fantastic organization, and I think the most important thing is you just support your staff and do the best that you can every single day. And this too shall pass. When? But it will. At some point.
Thank you so much. Oh, but there was this one last one. So I have been told to reuse the reusable gown for the day because they're going through gowns so fast. Is that not a contamination issue? I think that is a contamination issue.
I wouldn't reuse gowns. I know that people have been using N95s by putting them in paper bags and then circulating it to the next week.
Mm-hmm. Yes.
But gowns are different. I mean, you know,
gowns are different.
Hard to doff and don on the home care, and basically it's just use once and toss it. That's my understanding.
Yes, that's right.
Yeah. Yep. Okay. All right. So we have to end. Sorry, everybody. But thank you for your engagement. And just a reminder, in order to get your CMEs, go to our website, complete the online evaluation form, and you can go ahead and do that. And we'll see you next week, July 1st, and we'll be talking about, God forbid, reopening strategies for our facilities. All right. Thank you, everybody.
Thanks, Mark.
Have a good day.
Thanks, Anna. Bye-bye. Thank you.